Okay, now let us start with chapter 61 of your Apurba Sastry Essentials of Microbiology, which is about bacterial Lobar pneumonia. In this chapter, we will be previewing pneumococcal pneumonia, Haemophilus influenza pneumonia, staphylococcal pneumonia, gram-negative bacilli pneumonia, and the rare causes of bacterial pneumonia. In this video, we will be covering pneumococcal pneumonia and the pathogenesis of Haemophilus influenza pneumonia, while the lab diagnosis and the subsequent types of pneumonia will be covered in the subsequent videos. Introduction. Based on area of lungs involved and type of cough produced, bacterial pneumonia is traditionally classified into two groups: typical lobar and atypical or interstitial pneumonia. Lobar or typical pneumonia involves infection of the lung parenchyma and its alveoli. It is characterized by consolidation, which gives a dull note on percussion, and productive cough with a purulent sputum. It is mostly caused by pyogenic organisms such as Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus, and gram-negative bacilli. Interstitial or atypical pneumonia occurs in the interstitial space of lungs. Cough is characteristically non-productive. It is mostly caused by bacteria such as Mycoplasma, Chlamydia, Legionella species, etc. However, there is considerable overlapping. The typical agents can be atypical in presentation and vice versa can also be true. Clinical features which may be found in both types of pneumonia include fever with chills and or sweats, tachycardia, increased respiratory rate, tachypnea with increased use of accessory muscles of respiration, dyspnea or the shortness of breath. If pleura is involved, the patient may experience pleuritic chest pain. Gastrointestinal symptoms may be seen up to 20% of the patients, such as nausea, vomiting, and or diarrhea. Other symptoms may include fatigue, headache, myalgia, and arthralgia. Severely ill patients may develop septic shock and multi-organ failure. In lieu of epidemiological point of view, pneumonia can be classified into community-acquired. Patients acquire the infection in the community, the healthcare associated, in which patients acquire the infection in the hospital setting. This chapter will focus mainly on the typical bacterial agents causing lobar pneumonia. Pneumococcal pneumonia. Streptococcus pneumoniae, commonly referred to as pneumococcus, is the leading cause of lobar pneumonia, otitis media in children, and meningitis in all ages. They are alpha hemolytic and may present as commensals in human upper respiratory tract. They differ from alpha hemolytic viridans streptococci in many ways, such as their shape, lanceolate shaped diplococci, bile solubility, optocin sensitivity, and presence of a polysaccharide capsule. Virulence factors and pathogenesis. Staphylococcus pneumoniae, Streptococcus pneumoniae possesses a number of virulence factors. Capsular polysaccharide is the principal virulence factor, protects the cocci from phagocytosis. Typing of pneumococci is based on capsular polysaccharide structure. Till date, there are 98 serotypes reported. C carbohydrate antigen, C polysaccharide. This antigen precipitates with an acute phase reactant protein called as C reactive protein CRP. CRP is not an antibody to pneumococcal C antigen. It is a marker of acute inflammation raised in many acute inflammatory conditions. Differences between Streptococcus pneumoniae and Viridans streptococci. Arrangement of Streptococcus pneumoniae gram-positive cocci in pair and Viridans are gram-positive cocci in long chains. Morphology of pneumoniae, they are lanceolate shape while viridans are round or oval. Capsule present in pneumoniae, absent in viridans. On blood agar, Drotsman or carom coin colony are produced by Streptococcus pneumoniae, while minute colonies are produced by viridans streptococci. Bile solubility, Streptococcus pneumoniae colonies are soluble in bile, while the viridans streptococci colonies are insoluble in bile. Aniline is fermented by pneumoniae while not fermented by viridans, and optocin, Streptococcus pneumoniae is sensitive for this while viridans streptococci is resistant. Now coming on to pneumolysin, it is a membrane damaging toxin which inhibits neutrophil chemotaxis and phagocytosis, similar to streptolysin O. Autolysin, it is an amidase enzyme that cleaves its own peptidoglycan, leading to autolysis of cells. This property is responsible for the characteristic bile solubility and Drotsman appearance of pneumococcal colonies. Release of cell wall fragments leads to self-perpetuating inflammatory response that contributes to pathogenesis. Other virulence factors include pneumococcal surface proteins PSPA, PSPC, IgA protease, neuraminidase, and pneumococcal surface adhesin A, PSA. Clinical manifestation: pneumococci first colonize the human nasopharynx, which usually occurs at an early age. From the nasopharynx, the bacteria spread either via the bloodstream to distant site, example brain, joint, bones, and peritoneal cavity, or spread locally to cause otitis media or pneumonia. Various manifestations include lobar pneumonia. Streptococcus pneumoniae is the most common cause of lobar or alveolar pneumonia. Though starts as non-invasive illness due to contagious spread from the nasopharynx, it soon becomes bacteremic and invasive. Patients present with productive purulent cough, fever, and chest pain. Important signs are dullness on percussion due to consolidation and crackles on auscultation. Empyema and parapneumonic effusion may occur as complication of pneumococcal pneumonia. Invasive pneumococcal disease (IBD) defined as an infection confirmed by the isolation of pneumococci from a normally sterile site. Various examples include bloodstream infection, pyogenic meningitis. Streptococcus pneumoniae is the leading cause of meningitis in all ages. Other invasive manifestations such as Streptococcus pneumoniae can cause osteomyelitis, septic arthritis, endocarditis, pericarditis, primary peritonitis, and rarely brain abscess and hemolytic uremic syndrome. Non-invasive manifestation pneumococci can cause various non-invasive infections such as otitis media, most common, and sinusitis. Epidemiology source of infection is the upper respiratory tract of carriers, less often the patients. Carrier rate up to age of 5 years, 70 to 90% of the children harbor streptococcus pneumoniae in the nasopharynx. In adults, the colonization occurs less frequently, nearly 40%. Mode of transmission is by inhalation of contaminated droplet nuclei. Infection usually leads to colonization of and carrier state. Disease resolves only when the host resistance is lower due to the presence of associated risk factors. Risk factors. Children less than 2 years, children are at the higher risk to develop pneumococcal infection because of their inability to produce adequate antibodies against the capsular antigen owing to the immature immune system. Splenectomy, sickle cell disease, and other hemoglobinopathies, as spleen is the site of destruction of capsulated bacteria. The conditions where the opsonization and clearance of circulating bacteria by the spleen is hampered, there is an increased risk of pneumococcal infection. Underlying comorbid diseases such as chronic lung, heart, kidney, and liver disease, cochlear implants, diabetes mellitus, and immunosuppression, example HIV. Viral URTI, underlying viral upper respiratory tract infection, example influenza. Nature of infecting serotypes. Serotypes vary in their virulence, geographical distribution, and age affected. Most common 16 and 19F are reported universally as the major serotypes. In India, serotypes 1, 6, 19A, and 19F are commonly reported. Age in children, 7 serotypes 1, 5, 6A, 6B, 14, 19F, and 23F account for nearly 60% of IPD cases in most part of the world. In contrast, the serotypes causing IPD vary widely among adults, which may be attributed to the wide variation in the vaccination status in adults. Lab diagnosis of pneumococcal infection. Specimen collection, of course, is sputum, CSF, and pleural fluid. Direct smear microscopy reveals pus cells and lanceolate shaped gram-positive diplococci surrounded by a clear halo due to capsule. Capsular antigen detection in CSF by latex agglutination. See antigen detection in urine and CSF by ICT. Culture, blood agate forms Dotsman or carom coin-shaped colonies, and on chocolate agate produces greenish discoloration called bleaching effect. Culture smear reveals lanceolate-shaped gram-positive diplococci. Identification, biochemical identification is bile-soluble, optogen-sensitive inherent fermenter. Automation methods such as Marletov and Vitek. Serotyping by Quellung reaction or latex agglutination test. Molecular methods such as multiplex PCR. Non-specific findings, increased acute phase reactant proteins, example C-reactive protein procalcitonin, and antimicrobial susceptibility testing, of course, can be done. Now coming to the details of the lab diagnosis of pneumococcal infections. Generally, lab diagnosis of various pneumococcal infection is as discussed below. Specimen collection. Depending on the site of infection, specimens such as sputum, cerebrospinal fluid, pleural fluid, and other sterile body fluids are collected. Automated blood culture is useful for invasive infection. Other specimens include aspiration of sinus material and ear discharge or aspirate. Direct smear microscopy of smears made from specimens shows numerous pus cells and lanceolate or flame-shaped gram-positive cocci, 1 micrometer in pairs, surrounded by a clear halo due to capsule. Direct microscopy is extremely useful, especially for meningitis, and empirical treatment antibiotics can be started early. Antigen detection, capsular antigen detection of the capsular antigen is in CSF is more sensitive than microscopy. It is done by latex agglutination test using latex beads coated with anticapsular antibodies. See antigen detection of the C polysaccharide antigen in urine by immunochromatographic test ICT is useful for diagnosis of pneumonia. However, it gives positive results even for nasopharyngeal carriers. Therefore, it is not useful in children where the carriage rate is high. This ICT is also available for antigen detection from CSF in meningitis cases. Culture Streptococcus pneumoniae is fastidious, does not grow in basal media like nutrient agar or nutrient broth. Specimens are inoculated onto enriched media such as blood agar and chocolate agar and incubated for 24 hours at 37 degrees Celsius in presence of 5 to 10% of CO2. In this figure, we can see pneumococci in gram stained smear of sputum, lanceolate shaped gram positive cocci in pair surrounded by a clear halo because of capsule. Now, in blood agar, colonies are initially small dome shaped surrounded by green zone of alpha hemolysis. Colonies on prolonged incubation undergo autolysis and therefore have a central depression with an elevated rim, giving rise to Dotsman shaped or carom coin shaped appearance. On chocolate agar, it produces greenish discoloration, described as bleaching effect. Culture smear, gram stain smear of colonies reveals lanceolate or flame shaped gram positive cocci 1 micromethane pair. Motility testing is by hanging drop, it shows non motile cocci. Identification: pneumococci are catalase negative and can be differentiated from virulent streptococci, which are also alpha hemolytic, found as oral commensals in sputum specimen in various ways. Bile solubility: pneumococci are soluble in bile sodium deoxycholate due to their enhanced autolytic activity in presence of bile. Virulent streptococci are insoluble in bile. Optocin sensitivity. Pneumococci are sensitive to optocin disc and produce wider zone of inhibition 40 mm or more. Virulent streptococci are resistant to optocin. Inulin fermentation: pneumococci can ferment inulin to form acid but not virulent streptococci. Automated methods such as Maltitov and Vitek can also be used for early and accurate identification. This is very useful in early institution of pathogen directed therapy. Typing of Streptococcus pneumoniae: quelling or Neufeld reaction. This test was routinely done in the past at bedside directly from sputum samples from pneumonia cases. When specimen is treated with type-specific antiserum along with methylene blue and dye, capsule becomes swollen, sharply delineated, and refractile. Currently, serotyping is done by latex agglutination test using type-specific antisera. Molecular methods such as PCR are highly sensitive, more useful when organism load is scanty, example CSF, detect earlier than culture and also help in serotype identification. Real-time PCR is given even more sensitive, specific, takes less time and quantitative. Multiplex PCR, example BioFire film array or Biomedics, and multiplex real-time PCR can be used for simultaneous detection of common agents of Lobar pneumonia from sputum or bronchoalveolar lavage. In this figure, we can see the properties of pneumococci. A shows alpha hemolytic Dotsman shaped colonies on blood agar. B shows sensitive to optocin. C shows bleaching effect on chocolate agar. D shows bile solubility test. Left one shows virulent streptococci not soluble in bile, and right one shows pneumococcus soluble in bile. And figure E shows quelling reaction in which the capsule after adding antiserum becomes swollen. Okay. Common genes included in these are LIT-A, autolysin gene, PLY, pneumolysin, and PSA, pneumococcus surface antigen A. Non-specific findings: elevated acute phase reactant proteins such as C-reactive protein, procalcitonin, leukocytosis, chest X-ray shows infiltrates and lobar consolidation. In children, distinguished spherical consolidation is seen in upper part of the lower lobe. It's also called as round pneumonia. Antimicrobial susceptibility test, AST. AST is necessary for institution of appropriate antibiotic treatment. It can be performed by disc diffusion test on Muller-Hinton blood agar or by automated MIC detection method by microbroth dilution, example Vitek. The latter is preferred method as disc diffusion breakpoints of several antibiotics, example penicillin, ceftriaxone, are not available for pneumococcus. Pneumococcal infections treatment. The treatment regime for pneumococci varies depending upon the type of infective syndrome. Pneumonia, oral therapy with amoxicillin for 5 days remains the standard treatment for among outpatients. Alternative drugs include IV penicillin or ceftriaxone, oral quinolone, levofloxacin or moxifloxacin, clindamycin or azithromycin. Meningitis, as mortality is very high, 20%, treatment should be initiated as early as possible. Ceftriaxone, cefotaxime or plus minus vancomycin is given for 10 to 14 days. Other invasive infections for stable children, penicillin, cefotaxime or ceftriaxone can be instituted. In critically ill children, the treatment should be same as that of meningitis. Otitis media, oral amoxicillin for 7 to 10 days is the drug of choice. Drug resistance in pneumococcus. About 30% of IPD pneumococcus shows resistance to at least one antibiotic or more. Penicillin resistance in pneumococci has been reported increasingly nowadays. This resistance is due to the alteration of penicillin binding protein PBP to PBP2B. This altered PBP2B has low affinity for beta-lactam drugs. The drug coding for altered PBP is acquired by transformation and horizontal transfer of DNA from related streptococcal species. Multi-drug resistant MDR Streptococcus pneumoniae, non-susceptible to more than equal to 3 antibiotic classes is increasingly reported. Resistance to penicillin, tetracycline, erythromycin, sulfonamides, and clindamycin have been shown to coexist. Serotype 19A is the most common serotype to exhibit multi-drug resistance. Some serotypes can undergo capsule switching, change from one serotype to another, which may contribute to the development of antibiotic resistance. Prevention and vaccination measures to prevent pneumococcal disease include vaccination, treatment of underlying disease that uh, increase the risk of pneumococcal disease, infection control measures, droplet precautions, and prevention of antibiotic overuse. In this figure, we can see the types of pneumococcal vaccine. Mainly, they are PPSV23 and PCV13. PPSV23 is for 23 valent pneumococcal polysaccharide vaccine. Brand is Pneumovax 23, contains 23 serotypes of Streptococcus pneumoniae, covers 70 to 80% of the invasive serotypes in adults. Less immunogenic, provides short-term immunity, promotes herd immunity, does not provide mucosal immunity, has no effect on carriers, is less expensive, and indication for adults is more than 65 years age and 19 to 64 year age with underlying risk factors. Now, PCV13 is known as pneumococcal conjugate vaccine. Brand is Prevnar 13. Contains 13 serotypes of Streptococcus pneumoniae. Covers only 30 to 40% of invasive serotypes in adults. However, it covers most serotypes infecting children. More immunogenic, the protein conjugate acts as adjuvant and increases the immunogenicity of the capsular antigen. Hence, PCV is effective against children less than 2 years. Provides longer immunity, does not promote herd immunity, provides mucosal immunity, hence it can eradicate the carriage from nasopharynx. It's more expensive, and indications in adults are same as PPV SV23. In children, it can be given as primary immunization. Pneumococcal vaccine, there are two vaccines available for pneumococcus: 23 variant pneumococcal polysaccharide vaccine PPSV23 and pneumococcal conjugate vaccine PCV13. Schedule, the type of vaccine recommended and its schedule depends on the age group. Afterwards, PCV13 is recommended 3 primary doses at 6, 10, and 14 week and booster at 15 months. Age more than equal to 65 years, either PPV SV23 only can be given or PCV13 followed by PPV SV23 can be given by more than equal to 1 year gap. Age 19 to 64 years, pneumococcal vaccine is recommended only in presence of underlying risk factors. Depending upon the type of risk factors, either PPV-SV23 alone is given or PCV13 followed by PPV-SV23 is given. The risk factors are immunocompetent person with alcoholism and smoking, chronic heart, liver, and lung disease, diabetes mellitus, cochlear implants, and CSF leaks. Splenic dysfunction, congenital or acquired asplenia, sickle cell disease, or other hemoglobinopathies. Or immunocompromised persons, chronic renal failure, congenital or acquired immunodeficiencies, HIV infection, malignancy, and solid organ transplant. So this completes our Streptococcus pneumoniae factor. Now we come on to Haemophilus influenza pneumonia. Introduction. Haemophilus species are oxidase positive capsulated pleomorphic gram-negative bacilli that require special growth factors present in blood such as factor 10 and 5. Hemo means blood and philus means loving. Important species are Haemophilus influenza, most pathogenic species which causes pneumonia and meningitis in children. Other species encountered are Asphorus, H. ducreyi, causes sexually transmitted disease called chancroid which presents as genital ulcer. Haemophilus aegypticus causes conjunctivitis and rashes. Haemophilus hemolyticus and Haemophilus parahemolyticus produce hemolysis on blood agar. They are also commensals in throat or mouth. Haemophilus aprophilus and Haemophilus paraaprophilus, renamed as Aggregatibacter aprophilus and Aggregatibacter paraaprophilus, associated with infective endocarditis. Haemophilus parainfluenza can cause infective endocarditis. Subsequent discussion is confined to Haemophilus influenzae. Other species are discussed under the respective systems which they principally infect. History. Haemophilus influenzae is also called as Pfeiffer's bacillus that was discovered first by Pfeiffer. The species name was coined wrongly, thinking that it would cause human influenza, which is actually a viral disease caused by influenza virus. Virulence factor of Haemophilus influenzae are capsular polysaccharide is the most important virulence factor, acts by inhibiting phagocytosis. Other virulence factors include bacterial endotoxin, other membrane proteins, IgA1 proteases, and pili and other adhesion proteins. Serotyping based on the capsular polysaccharide of Haemophilus influenzae it can be typed into 6 serotypes. However, some strains lack capsule and are referred to as non-typable strains. Haemophilus influenzae serotype B, HIB, is the most virulent among all types and accounts for most of the invasive infections. HIV capsule has a unique chemical structure made up of polyribosyl ribitol phosphate (PRP) antigen. It is strongly immunogenic, induces IgG, M, and A antibodies, which are bactericidal, opsonic, and protective. Hence, PRP antigen is used for vaccination. Next to HIV, non-typable strains are commonly isolated clinically. Other capsular serotypes are very rarely isolated. Clinical manifestation of Haemophilus influenzae type B (HIB). Haemophilus influenzae type B is the most common and most invasive serotype of Haemophilus influenzae. It causes systemic disease by invasion and hematogenous spread from the respiratory tract to distant sites such as meninges, bones, and joints. Central nervous system infection can cause pyogenic meningitis and subdural effusion. Mortality rate is high if untreated. Epiglottitis is cellulitis of the epiglottis and supraglottic tissues. It is life threatening and can lead to acute airway obstruction. It typically affects older children 2 to 7 years old and rarely adults. Community acquired bacterial pneumonia (HIB) causes pneumonia in infants, which is clinically similar to other types of bacterial pneumonia, except that pleural involvement is more common in HIB infection. Parameningeal focus of infection is often present in adults, such as sinusitis and otitis, from which the infection may spread to meninges. Less common invasive conditions include cellulitis of neck and head region, osteomyelitis, septic arthritis, pericarditis, empyema and bronchiectasis, orbital cellulitis, endophthalmitis, urinary tract infection, bacteremia without an identifiable focus. Non-typable Haemophilus influenzae. Next to HIB, non-typable strains are the most common group encountered clinically. They cause disease by local invasion of mucosal surfaces. The clinical manifestation include childhood otitis media, most common cause, exacerbations of chronic obstructive pulmonary disease (COPD). They are the most common bacterial cause for the condition. Community acquired bacterial pneumonia in adults with underlying COPD or AIDS. Puerperal sepsis and neonatal bacteremia. These infections can be caused by non-typable strains that usually colonize the female genital tract. Now coming on to the differences between type B and non-typable Haemophilus strains. Capsule is made up of polyribosyl ribitol phosphate in type B strains, while of course non-typable strains are non-capsulated. Manifestations of type B is invasive, meningitis, epiglottitis, pneumonia and bacteremia. While non-typable ones have non-invasive manifestations like otitis media in children and pneumonia in adults. Type B strains commonly affect children while non-typable affect adults. Spread of type B is hematogenous while non-typable is contagious spread. HIV vaccine is available for type B while not available for non-typable strains. Now this continuing the non-typable H influenza, it says that sinusitis, it can cause sinusitis in adults and children. Rarely they can cause invasive infections, especially in countries where HIV vaccines are used widely. These the differences already we have discussed. Now epidemiology host Haemophilus influenzae is exclusively human pathogen. Mode of transmission is through respiratory route, either by droplet inhalation or contact with infected secretion or fomites. Age invasive Haemophilus influenzae infection is common in children less than 5 years of age and also adults more than 65 years of age. Risk factors such as household contact, daycare center, age linear and socioeconomic conditions and genetic differences. Incidence. The incidence of invasive HIV infection is drastically reduced due to the widespread use of HIV vaccine and now non-typable H influenzae strains cause the majority of invasive disease among all age groups. Now, the lab diagnosis of Haemophilus influenza infections. Specimen, of course, is sputum, blood, CSF. Processed immediately, should never be refrigerated. Direct examination reveals pleomorphic gram-negative cocobacilli. Capsule detection by Quellen reaction and antigen detection by latest agglutination test, direct immunofluorescence or ELISA. Culture blood agar with Staphylococcus aureus streak line shows satellitism. Others like chocolate agar, Fildes agar, and Levinthal's agar can also be used. Identification biochemical tests such as disk test for X and V factor, 10th and 5th. Automated systems such as Malitov and Vitek. Typing methods such as biotyping and serotyping using specific anti-sera. And molecular method multiplex PCR Wi-Fi film array detecting common agents of pyogenic meningitis in CSF. And of course, antimicrobial susceptibility testing can be done. Okay. So details of this we'll be covering in the next video. Like and subscribe. Thanks for watching.